So next up we have cardioversion. Always consider high risk of embolic stroke, especially if there was any breaks in anticoagulation for the 3 weeks prior. So the patient has known AFib coming in with RVR with unstable hemodynamics. Make sure that that patient was compliant with his anticoagulation for at least 3 weeks prior. Indications: urgent, ischemia, end organ hypoperfusion, signs of shock, systemic hypotension, and severe pulmonary edema. These are urgent indications. Elective indications: new onset AFib or unacceptable symptoms from persistent AFib. So synchronized electrical cardioversion, DCCV, you start with 150 joules like we talked about in the previous talk, and you can increase energy stepwise if sinus rhythm is not achieved. And of course, it's always good to sedate these patients with agents that don't drop the blood pressure, especially if hemodynamics is unstable, like ketamine or etomidate. Chemical cardioversion success rates are significantly higher for acute onset AFib, that's less than a week, 7 days, compared with longer duration AFib. So you can start with things like flecainide, the 1C, antiarrhythmics, propafenone, dofetilide, and ibulepride, and also amiodarone. IV infusion. It's kind of weakly effective for cardioversion, but you can do a PO load over 3 to 4 weeks, and especially if the patient is older person compared to younger, because of the side effects of amiodarone. And anticoagulation applies both chemical and electrical. Pre-cardioversion, if it's a definitive new onset, it's for sure less than 48 hours. May proceed with anticoagulation. If AFib onset is 48 hours, greater than 48 hours, or unclear, you would have to anticoagulate for 3 weeks prior to cardioversion, or obtain a transthoracic echo immediately prior to the cardioversion. And post-cardioversion, it's always good to anticoagulate for at least 4 weeks after the cardioversion. And even after reversion to sinus rhythm, based on CHA2DS2-VASc and Hasbled scores. So kind of each patient has to be assessed separately. For next talk, we're going to be talking about the CHA2DS2-VASc score, what goes inside the score and how it's calculated, as well as the Hasbled score, and potential recommendations for anticoagulation as well.